Welcome to Neuro Frontiers, a series in which Practical Neurology partners with ReachMD to discuss topics at the forefront of clinical research and advancements that further clinicians' ability to diagnose and treat neurologic conditions. Preventable harm is a serious concern for patients with Parkinson's disease who receive care in the hospital setting, even when admitted for reasons other than their diagnosis. In this episode, Peter Pronovost, MD, PhD, Chief Quality and Transformation Officer at University Hospitals Cleveland Medical Center, discusses his work in developing new hospital care standards for reducing medication mismanagement and improper or insufficient care.
Thank you so much for joining us today on this episode of Neuro Frontiers. I'm Billy Irving, and I'm here with Dr. Pronovost. Dr. Pronovost, could you briefly introduce yourself?
I'm Peter Pronovost. I'm a critical care physician, and I serve as the University Hospital's Chief Quality and Clinical Transformation Officer.
Thank you so much. And could you tell us a bit about the article you co-authored on recommendations for avoiding harm through hospital care standards for people with Parkinson's disease?
Yes, I've been partnering with the Parkinson's Foundation as a strategic advisor about how to improve care of hospitalized patients that have Parkinson's disease. And a couple just key statistics for people to understand. Parkinson's disease is the second most common neurodegenerative disease in the U.S. after Alzheimer's. There's nearly 1 million people in the U.S. with Parkinson's disease. 300,000 people with Parkinson's disease are hospitalized in each year, and 75% of these do not receive their medication on time while they're in the hospital. The key findings of the paper then in that context are that people with Parkinson's disease face a disproportionate rates of preventable harm and unintended harm when they're hospitalized. And they're particularly at risk because most of our safety programs in hospitals are built around what you're diagnosed with. So if you come in with a heart attack, we have protocols or order sets to help make sure you get the right care. We have much less robust programs for people who have a risky condition, in this case, Parkinson's disease, but they're admitted for something else. So most of those people with Parkinson's disease aren't admitted for Parkinson's disease. They're admitted for something else, but their disease increases their risks. There's also a growing prevalence of people with Parkinson's disease, and why, with the aging population, we have to make sure we address it. We also reported that there's a growing consensus on what are effective and sustainable solutions that hospitals could implement in preventing harm amongst Parkinson's disease patients. This work was initiated with the Parkinson's Foundation publishing a hospital care recommendations article on their website, which established a pretty robust quality improvement framework that hospitals can use to help in caring for patients with Parkinson's disease and ideally prevent the harm that they're at risk for. The evidence supporting these recommendations is really growing and continues to grow as the Parkinson's Foundation has member hospitals working on a learning collaborative. So we're trying to sort out how best to implement these recommendations, how to have the resources, how to measure them, how to identify people with Parkinson's disease, and we're learning quite rapidly. And the reality is that despite the consensus on these recommendations, there's been relatively limited implementation of these interventions across hospitals, and we'd love to see a much broader and robust quality improvement effort that seeks to eliminate harm in Parkinson's patients when they're hospitalized.
So why were these recommendations needed? Could you tell us a bit about what types of harm people with Parkinson's disease were experiencing when they were in the hospital?
Sure, yeah. Parkinson's disease patients are at risk for a number of types of harm. One is harm from medication. Two is harm from low mobility. And three is harm from aspiration or aspiration pneumonia. And the recommendations that we have are all focused on addressing those risks of harm. For example, that we make recommendations that all patients with Parkinson's disease have their medicines ordered in a fashion that they're used to at home, and that they're delivered within 15 minutes of their normal at-home regime 100% of the time. Now, that may sound common sense, but many patients with Parkinson's disease need to take their medicines every 3 hours or on shorter regimens even, and they're highly sensitive to delays or deviations from that regimen. But as you probably know, hospitals are busy places, and many hospitals don't have standards to give medicines with that degree of precision. And so we have to make sure we identify patients with Parkinson's disease and then make sure their medication is timely and like their home. We also make sure that patients with Parkinson's disease do not receive dopamine blocking agents or other agents that might cause them harm. They're particularly at risk for certain medications to have a bad reaction. That patients with Parkinson's disease should be mobilized 3 times a day if clinically appropriate, because again, if they don't, they lose mobility, and they often, that loss of mobility continues when they leave the hospital. And then finally, all patients with Parkinson's disease should be screened for dysphagia, that is a swallowing disorder, within 24 hours, and that measures should be taken to reduce the risk of aspiration pneumonia as needed. Once clinically we identify a patient at risk for aspiration, there's things we can do to mitigate that risks, but we have to test patients to make sure they are. So those are the recommendations that we think, if systematically applied within hospitals, could materially work to reduce the risks to Parkinson's disease patients.
So how are these recommendations developed?
They were developed through a review of the literature, through working with experts in the field and consensus, and then after testing and piloting in hospitals to say what's feasible and what's not. I think, the recommendations, like we said, have a high degree of face validity. I mean, if patients suffer harm from not getting their medications on time, then give them their medications on time. If they, suffer from not being ambulated or not having mobility, then let's make sure we do that. And likewise, from aspiration is screen for it. I would say the harder part is finding how to make this work in hospitals, because most of the information systems don't have a mechanism yet or in place to identify when someone's admitted with Parkinson's disease. How do I flag that so then I can trigger other activities, right? We mostly admit with a diagnosis, and some of those other codes, like what other diseases do I have, are added to the medical record later. And so making sure we can flag people if they have Parkinson's disease right on admission so that we can trigger these other activities. The other piece is just coordinating the workflows. For the medications, it's working with pharmacy to make sure that, we have a process to make sure patients get these medicines in a timely way. And if that's not their norm, then making sure we create a new workflow just for Parkinson's disease patients. That is going to be helped by a new CMS condition of participation about having hospitals ensure they're providing age-friendly care. And one of the components of that condition of participation is to give medications on time. So there's a broader effort that hospitals will be required to do. And I think this Parkinson's disease Foundation recommendations will fit very nicely with that. Likewise, when we're ambulating patients or mobility, some clinicians may be worried that Parkinson's disease patients may fall, or we have assistance to help them walk. So they may be less likely to get ambulated, and making sure that we have both the cultural awareness in place that yes, ambulation is essential for these patients, and that they have the support to do it safely. And again, like the medications, if we could identify patients on admission, then we can screen them for dysphagia and mitigate their risk of aspiration.
Thank you so much. And I think you touched on this next question, but how else do you think these recommendations might affect the care provided by neurologists? Is there anything that our audience who are practicing clinical neurologists should do differently?
So one, I think that neurologists should be aware of these recommendations. Clinically, they're all common sense, as I said. I'm sure that they know them, but also see the article, because we talk about ways to implement them. I also think, and I would love to see the neurologists who treat Parkinson's disease patients lead efforts in their hospital to implement these. They have the clinical expertise about the drugs and all the things on the checklist. They will need to partner with staff in quality, probably pharmacy, probably the hospitalist service, because that's where many of these patients are admitted into, or the surgical services. But they could champion an effort to make sure 100% of Parkinson's patients receive these interventions. Even if they may not consult for all of them or be involved in the care, they can design a care system to make sure these patients get the therapies that will keep them safe. We have a saying in quality that every system is perfectly designed to achieve the results that it gets. And right now, we have a system that's perfectly designed to cause some harm to Parkinson's patients. I think these neurologists who are passionate about the care of Parkinson's patients could really help accelerate this change throughout America. And I look forward to see the impact that they could have.
What's on the horizon for these recommendations? I'm wondering whether there's like a timeline for implementing these recommendations and whether it will be assessed how they've been implemented in the future, looking back.
This is an active area of what we call implementation science research. Implementation science simply means when we know something works, how do we find out how to ensure that we actually implement it and patients receive it, and then whether it works to improve the outcomes, but also how and why, so we can scale those interventions most effectively. And we're in that implementation phase of research. So we have a number of hospitals working with the Parkinson's Foundation to test and implement these strategies and learn together, what works. How do you make sure you get your medicines on time? How do you make sure you ambulate all patients? And we just had a webinar the other day on ambulation. And we're also studying to see what's the impact of these. And so we have still limited data on the baseline rates of harm for Parkinson's disease patients. We have some, but really understanding how often they're harmed, what the impact of it is, and then making sure that we document and learn how much of that harm is reduced by implementing these interventions. So it's a pretty exciting time. I think there's enough that we know, and the paper and the foundation's articles outlines the detailed clinical things that we should be doing, that our neurologists should be going within their hospitals to help partner with the quality department to broadly implement this throughout their hospitals.
Thank you so much. And just one more thing. Do you know whether there are any efforts to develop similar recommendations for other conditions like Alzheimer's disease or ALS or any other conditions that might be affected by harm in the hospital care setting?
Yeah, so Billy, really good question. I published a separate paper in BMJ Quality and Safety addressing your exact concern, or about what I would call this category of risk that healthcare has been largely blind to or less focused on. And that is, there's certain diseases like Parkinson's disease for which patients are often not admitted for, they're admitted with, but that materially increase their risk of being harmed in the hospital, right? So Alzheimer's disease is another one, severe mental illness is another one where patients, are very high risk of aspiration if they don't get their medicines times, of lack of mobility. And the article was a call to say, let's get these lists of conditions that increase risk of patients' harm and make sure we build systems to mitigate those risks. I think for many of them, like the Parkinson's disease or the paper we wrote, the things to do are well known by clinicians. We just haven't built a system to ensure that they do. And so maybe that, this group of neurologists or your readers could opine about what are those neurologic diseases that increase patients' risk of harm, and begin to make sure we develop care programs to mitigate them.
Thank you so much. It was really great speaking with you, and I thank you so much for your time today.
Yeah, thank you. Have a great day.
Thanks to Dr. Pronovost for sharing his knowledge with our listeners in this episode of Neuro Frontiers. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the field of neurology.